thank you. Can I just say for the junior neurosurgeons in the audience, to drill off a petrous endostosis is a very uncomfortable operation. Yeah, do not do it in your first year of practice. The next talk is Jason Schwalb, who should be online, and he's going to talk about how to build a clinical quality initiative. Dr. Schwalb, there he is.
Can you hear me, Chris?
We sure can, and we see your slides. Over to you.
Okay, great. I apologize. I really tried to get there yesterday, but Air Canada had other ideas. So I'm going to actually talk about something a little bit different in terms of what I think, kind of next step is for us as a field if we want to really collect a large bunch of data, because except for a couple of groups like the OHSU and now the Columbia group, it's hard to get huge numbers. So I'm going to talk about our experience at running a spine collaborative here in the state of Michigan. So we were fortunate enough to get a lot of support from Blue Cross Blue Shield of Michigan, which is a not-for-profit insurer that covers about 70% of privately insured patients in the state. The Michigan Spine Surgery Improvement Collaborative, or MISIC, is one of 23 such CQIs, which include clinical quality initiatives for bariatric surgery, urology, hip replacements, and even non-surgical things like anticoagulation and diabetes. MISIC is actually involves both orthopedic and neurological surgeons across the state seeking to improve the care and outcomes following surgery for degenerative spinal disease. And a lot of this is management of and tracking patient-reported outcomes after surgery or PROS. So we are now on wave 6. We've been at this about 8 years now, and you can see we started with about 6 hospitals or 7 hospitals, and now we're really all over the state. Basically, any center that does more than 200 spine surgeries a year is involved, and we are even involving a couple of ambulatory surgical facilities at the insistence of Blue Cross Blue Shield. We are entering at this point. We have 125,000 cases. We're entering about 1,100 cases per month, both cervical and lumbar, and we're collecting pre-surgical H&Ps, surgical decision-making, procedural details, postoperative hospital courses, and then patient-reported outcomes at baseline, 90 days, 1 year, and 2 years. It's a huge effort. This is the coordinating center staff, including me and our director, Muaf Abdelhak, co-director Vic Chang, and all the support, including like 4 statisticians, which I think is 2 FTEs. If we're going to try and do something like this for facial pain, one of the most important things, and I'm involved in another registry which this wasn't done, it's actually been a huge problem, is if you do it as quality improvement, it is not research. And so we had to go to, we've had to go to over 20 hospitals to get IRB sign off when building the registry and the collaborative, so that there's no need for consent. So the problem with, if you're going through consent, is there's a huge amount of selection bias, both in the physicians who are recruiting patients, because they're only recruiting patients who are typical or they might think are doing well, and also for the patients, it's only the patients who are kind of interested in doing this kind of thing. So consent really introduces a lot of selection bias and subverts the whole point of quality improvement. That being said, if we're ever going to publish anything from our findings, we do get IRB oversight for any published research to disseminate our findings. And since 2015, we have 25 peer-reviewed publications. It's a lot of data. And I think probably the important thing to note here is this is from our original manual of operations. It's 250 pages. We have an executive committee that really agrees on the data fields. We really are very concerned about burnout for our abstractors and for our patients. So we don't try and add anything without also retiring old data fields, and are very concerned about the burden for PROMs to avoid survey fatigue. And we really try and minimize the burden on surgeons for reporting, be it with templated clinic and op notes or other things like that. As part of this, I've actually worked really hard at Henry Ford, where I work, to integrate PROMs into routine care, not just for spine surgery, but also for my facial pain patients. And we actually have been able to collect a huge amount of surveys. About 25% are pushed or answered online about, within 2 weeks of the appointment, and about 75% are filled out on check-in. And this is sort of what this looks like. We send out PROMs electronically prior to the visit. If they don't fill it out, this is what our check-in staff sees. They say, is the iPad needed? And if the answer is yes, they click on this, they get a QR code, they scan it with an iPad, and then hand the iPad to the patient and they fill it out. And we actually have been able to get, really very good data. I mean, if you look at the y-axis here, you see we're collecting like 85% in our collection rates over time, and it is continuing to get better. If we look at the different locations, there is some variability within our 6 clinical locations. Where I am at West Bloomfield, we're at like 93% completion rates for assigned forms, within the past year. And this isn't just patient-reported outcomes. This also, so we've been using mostly PROMIS, which is through the NIH, for things like pain interference, depression, physical function, as well as the EQ-5D. But we're also getting, huge amount of data fields in terms of like John Lee's brief pain inventory or Penn facial pain scale. We're getting not so good, about 50%. And we have sort of a standardized facial pain history questionnaire, really modeled off of Kim Burchell's work as well, that makes the clinic visit go very easy. And then those are discrete data fields that we can abstract. And as you can see, over the past year, really, and we only started this about a year and a half, we've given out 20,000 either surveys or patient-reported outcome measures with an 80% or 78% response rate. What do we do with the data? The data is actually owned by the surgeons. We are fortunate to have a pretty large budget so that we can do extensive auditing and check data integrity. The surgeons can really see their own data and blinded collective data, and then our data is analyzed and presented at CQI meetings. The targets are determined by the surgeons, and it's been really important. We have really great partnership with Blue Cross Blue Shield in that they really do not ask to see the data or determine any sort of reimbursement based on the data. It's been very important to keep that separate, so there's no big conflict of interest, and so surgeons don't feel, or hospitals don't as well, don't feel there's a risk of reprisal. And this is sort of what one of the outcome measures looks like on our MISIC dashboard, on push reports, and all the data is risk adjusted. And there's a huge amount of data. Obviously, with spine, we're looking at different levels and things like that. I think for facial pain, we have 5 or 6 different procedures, and we can kind of sort them out. And frankly, I don't think the number of data fields would be quite as high. But clinical quality initiatives are a lot more than just registries. We really look for high-performing sites and identify best practices. We really looked at our data in the first year or two, and we're looking at 90-day outcomes and looking at complications. And we identified like a small hospital in Grand Rapids, a small Catholic hospital in Grand Rapids, that was really doing very well on urinary retention, surgical site infections, and kind of went and tried to figure out what the hell they were doing. And we're able to get continuous feedback. We have 3 meetings a year, used to be all in person, now some are virtual, and frequent conference calls with our orthopedic and neurosurgical surgeon champions. And we try and get the non-Henry Ford Coordinating Center sites up on the podium. We have guest speakers, data analysis, QI initiatives, and results, and then some case studies. So this is how care has been changed in our state. We really wanted some early wins, so we looked at 90-day outcomes and really complications. It takes some time to get 1 and 2 year data where you can really start looking at that. But we've been able to reduce SSI by 15%, reduce hospital readmissions by almost 20%. We didn't really think of urinary retention going into this, but it's ended up to be a huge driver just because it was so common, and we're able to reduce that 70%. That's made a huge difference in length of stay and cost. And one of the ways we did that is we looked at our data across the collaborative and found that ambulating patients within 24 hours, and now a more recent paper within 8 hours, seems to make a huge difference in complications, ileus, SSI, and especially urinary retention. And an analysis of about 4 years of our data, just in terms of reduction in readmission, urinary retention, we estimated that we saved healthcare in our state $51 million. So when Blue Cross Blue Shield, needs to go to their payers or Ford Motor Company or wherever their subscribers are and say, why are you spending money on quality improvement? We're actually giving them numbers in cold hard cash that show that this is successful. Now that we have some successes from our 90-day data, we can start looking at more closely at things that influence long-term outcomes, such as choice of procedures, fusion versus non-fusion, things like that. And I think we could do something similar with facial pain. We had a lot of resistance, I think, from some of our surgeons. They were very skeptical about having people coming in and look at their data. Frankly, we spent a lot of time going to private practice groups because they were concerned about their own hospitals coming into their offices and looking at their charts and going through their data. But we've been able to do this in a way that we've been able to be a rising tide that lifts all boats. And this is a very competitive market, especially in Southeast Michigan, and have improved spine surgery outcomes in a cost-effective way. And really, collaboration has been the key from site to site with Blue Cross Blue Shield and with other surgical collaboratives. We have I'm part of a steering committee that covers all 23 CQIs and is trying to look at health equity and socioeconomic disparities and what we can do as a larger group to really influence that. I'm going to finish up. I do have one disclaimer that I've been instructed that I need to include, that although Blue Cross Blue Shield and MISIC work collaboratively, the opinions, beliefs, and viewpoints expressed by the author do not necessarily reflect the opinions, beliefs, and viewpoints of Blue Cross Blue Shield or any of its employees. Support for MISIC is provided by Blue Cross Network and BCBSM as part of the Value Partnerships Program. So thank you. And actually, since I see I have a minute or so, this is sort of what our data looks like at Henry Ford, and these are all kind of abstractable. This is just a patient I saw, within the past few weeks, and we're able to get these data and then analyze them. And this is what that looks like. Thank you.